Hello, everyone, and welcome to your lecture on the critical appraisal of randomized controlled trials of therapy. Today, we're going to mostly focus on how to critique randomized controlled trials, and we're going to focus on the study design portion for now. So, why do we want to learn about critical appraisal in the first place? Well, it's really important to understand how to critique published studies or published randomized controlled trials in a specific kind of way, because it's important to be able to understand the quality of published randomized controlled trials in order to allow you to view the results critically and then be able to form your own opinion on the article based on the risk of bias and also understand the context in which the results of the published RCT might be applied. So critical appraisal is likely the most important skill you're going to learn throughout the course of your university studies. It's the ability to look at information and to be able to form your own opinion on it based on your set of skills and expertise. So in my mind, this is a really important skill, and this is specific to RCTs, but I think you'll learn a lot about the process. So you're also learning about critical appraisal of RCTs because one of the major projects in the course is the design of an RCT. You're going to work in groups and design protocols of RCTs. So if you understand, what makes up a bad RCT, that's going to enable you to design a good RCT for yourself. So that's really, really important. And overall, through this process of critical appraisal in this, formalized sort of way, what we really want to understand is how serious the risk of bias is in a given study. So recall back to our lecture on errors in study design. Bias is essentially error in a study, and it's systematic error. And systematic error can be the result of confounding, selection bias, and information bias. So bias means that you're getting the wrong answer after you conducted your particular study. You have your hypothesis and you have your research question, but if a study is biased, the answer you're getting to your research question through the conduct of your randomized controlled trial is going to be wrong. So that's important to understand. So just a side note, we're going to focus on just the study design critical appraisal portion today. So just essentially up until the methods section of a published study. We're going to worry about the results section and the conclusions section and some calculations later on in the course after the statistics section, since you'll be able to understand that a little bit better after some statistics training. So again, we're just focusing on critical appraisal of study design at the moment. So similar to what I talked about in the first trial lecture, you really want to start out with understanding what the research question is for the article that you're critically appraising. And recall, this is the PICO question or the PICOT question. And this is the question that the authors are trying to answer in their particular study. So this is typically found at the end of the introduction section, and it can also be called the objective of the study. So again, the PICO question should be made up of the PICO components, which is the population, the intervention, which is typically the study, medication, or the new medication that you're looking for safety, efficacy, or effectiveness of. The C is the comparator. So this is either placebo or another active medication that's on the market that you're comparing your new medication to. The O is the outcome. So it's the safety outcome or the efficacy or effectiveness outcome that you're wanting to evaluate for your new study medication. And then T is time. So over what time period are you evaluating the outcomes of your medication compared to either placebo or the active comparator. So when we're critically appraising an article, we want to start off by asking whether or not the intervention and the control group started with the same prognosis. So By prognosis, I mean whether or not the two study groups started off with the same probability of experiencing the outcome. So what this means, and recall back to our lecture on our trials lecture on balance between the intervention and control groups, if the intervention and control groups have similar characteristics, then they have the same prognosis for the outcome that you're studying. So what this means is that your intervention group is going to have similar characteristics with respect to your control group, and they're going to be balanced and they're going to be comparable. The only thing that's different between your intervention and control group is going to be the treatment that they're receiving. So this means that you can narrow in on the independent effect of the medication, holding all the patient characteristics constant. So this is what I'm talking about. We want to make sure there's no confounding. We want to make sure that the patient characteristics are balanced between the intervention and control group. And, words like patient characteristics, prognostic factors, risk factors, those are all kind of interchangeable and the same in this context. So that's what we're going to start off by evaluating. So first off, in order to answer the first question, we want to determine whether or not patients were randomized. So of course you think that, oh yeah, it's a randomized controlled trial. Why wouldn't the patients be randomized? But it's important to keep in mind that randomization doesn't always succeed in creating groups with similar characteristics. So sometimes investigators can make mistakes that compromise randomization, or randomization might fail due to random chance. So the first way randomization can actually fail is when investigators who are enrolling patients are actually aware of the arm that the next patient is going to be allocated to, and they shouldn't be. People who are enrolling patients are supposed to be unaware and shouldn't be able to control the arm to which a patient is allocated to, the treatment arm. And if this is concealed, we say that randomization is concealed. And this goes back to allocation concealment in our previous trials lecture. So if a trial is unconcealed or allocation is unconcealed, investigators who are responsible for recruitment might actually systematically enroll sicker or less sick patients to either the treatment or control group. And this will compromise randomization. And this will result in a biased study, meaning that you're going to get the wrong answer as to whether or not your new medication on the market causes a particular outcome compared to placebo or comparator. Because this compromises the purpose of randomization. Typically, if allocation is concealed, the two groups are going to be identical with respect to both measured and unmeasured characteristics. But if a recruiter is, enrolling more or less sick patients in a particular group, then the two groups will not be balanced with respect to patient characteristics or confounders or prognostic factors. So we have to ensure that randomization is concealed. And this is done through strategies like remote randomization, where an individual patient that's going to be recruited in a study or enrolled in a study makes a call to a remote center. That's supposed to be a remote center, not method center. I'll change that in the slides. In order to discover the arm of the study that they're assigned to. So they'll just get an assignment. This patient still shouldn't know whether or not they're in the intervention and control group. So that's related to strategies to ensure allocation concealment. So the next question we have to answer or determine is whether or not patients in the treatment and control group are similar with respect to known prognostic factors. So again, these are just, patient characteristics that are risk factors for the outcome that we want to be balanced between the intervention and control group. So we ensure that we're making a fair comparison between the two groups. The two groups are similar with respect to both measured and unmeasured confounders. So again, the purpose of randomization, as I mentioned, is to create groups whose prognosis with respect to the outcome is similar. So again, if, for example, we're looking at a randomized controlled trial of a medication and the outcome is the occurrence of a stroke, we would want to make sure that age is balanced between the intervention and control group, because increasing age is a risk factor for stroke. So, if the mean age in the intervention group is 80 and the mean age in the control group is also 80, then we're pretty confident that age is equally distributed between the two groups. But sometimes, just through bad luck or random chance, randomization will fail to achieve this comparability of the two groups. And the smaller the sample size, the more likely that you'll have prognostic balance, or there might be an imbalance of patient characteristics between the two groups. So another risk factor for the occurrence of a stroke is something like previous history of high cholesterol or something like that. So, for example, if mean cholesterol levels in the intervention group are much higher than mean cholesterol levels in the control group, then this factor would not be balanced between the intervention and control group, and the prognostic balance between the two groups isn't achieved. So we can check how effective randomization has balanced prognostic factors by looking at a display of patient characteristics between the treatment groups and the intervention groups at the beginning of the study. So the beginning of the study is typically referred to as the baseline or entry of the study. So the way we actually look at this in a published paper is typically within a table 1. So what you're going to see is an overall patient characteristics, and then you're going to see patient characteristics according to the intervention and the control group. So what you want to look for is that the prevalence or mean values of patient characteristics or prognostic factors is the same between the intervention and the control group. So again, we look at measured patient characteristics in these particular situations, because we're not able to evaluate unmeasured patient characteristics. But if we know that the measured patient characteristics are balanced, then we have more confidence that unmeasured patient characteristics are balanced. So by unmeasured patient characteristics, I mean things like, for example, a genetic profile. So we know that genetics can actually increase or decrease the risk of a stroke or family history. We're not actually able to measure family history of a stroke, where we might not have access to a patient's genetic profile, but we would assume that the genetic profiles between the intervention and the control groups, the distribution of each is quite similar between the two, just because we see that there's balance and other characteristics between the two groups. So moving on, so we were looking at prognostic balance at the beginning of a study, but it's also really important to ensure that prognostic balance is maintained as the study progresses. So we're going to determine how we answer that particular question. So first of all, we need to determine whether or not the study was blinded, or the extent to which the study was blinded. If it's important to understand that if randomization succeeds, the treatment and control groups are going to begin with a similar prognosis. There's balance with respect to patient characteristics between the intervention and the control groups. But randomization at the beginning of the study doesn't provide any guarantees that the two groups will remain similar as the study progresses. And blinding is the optimal strategy for maintaining prognostic balance. So recall back to our trial lecture, blinding is all about whether or not an individual within the study knows the particular treatment assignment for a given patient. So they know whether or not the patient is actually in the intervention or the control group. So patients need to be balanced in order to avoid placebo effects. So if a patient knows that they're in the intervention group, this might change their behavior or their response to a particular questionnaire when they're being asked about their outcome. So remember back, we're talking about subjective outcomes like pain. If pain is reported by the patient and the patient knows they're in the intervention group, they might actually underreport their pain because they are perceiving the effect of the treatment to be higher. So that's really important to ensure that doesn't happen. Clinicians need to remain balanced because, or not balanced, blinded rather, because this is important for preventing differential administration of therapies that affect the outcome or co-interventions. So what I mean by this is, for example, if we're looking at a study that's looking at a medication that treats pain, if an individual clinician knows that a patient's maybe in the control group and the patient's experiencing a lot of pain, they might be more likely to prescribe an additional pain medication to the patient that isn't the study medication, such as, paracetamol or an NSAID or, another type of medication. They're more likely to do this if they know the patient's in the control group, whereas they might not actually do this if they know the patient's in the intervention group. So this is really important to keep clinicians blinded. Data collectors need to stay blinded because it prevents bias in data collection. So, if you're assessing a patient for their pain levels and you know that they're in the intervention group, you might be more inclined to kind of probe them a little bit further when you're asking them questions. They could answer something about their pain levels and the assessor might go, oh, are you sure about that? Like they might follow up a little bit more with assessing pain outcomes than they would if they knew the patient was in the control group. So it's really important to keep all that consistent between the intervention and control group. And a way to do that is to ensure data collectors are blinded. And this is similar with respect to the adjudicators of the outcome. Data analysts need to be blinded because then that's meant to avoid bias in decisions regarding the data analysis. So blinding is really important to ensure that patient characteristics remain the same between the patient and the intervention and control group, and the collection of data remains objective and consistent between the two groups. So again, we talked about co-interventions and how they can affect the study outcomes. It can bias the results. Again, we talked about whether or not people who are actually measuring the outcome might document things differently if they know the patient's in the intervention or control group, and this can lead to information bias. And if clinicians aren't blinded, then they can differentially treat different groups of patients if they know they're in the intervention or control group. So that's really important to identify, is whether or not the study was blinded and the extent to which the study was blinded. So, if only the patients are blinded, recall that's a single blinded trial. Patients and clinicians are blinded, that's a double blind, triple blind, and then quadruple blinded trial if everybody in this box is blinded. Okay, so the next question we want to determine is whether or not patient characteristics remain balanced between the intervention and control group at the study's completion. And another way of saying this is determining whether or not the prognostic balance was maintained at the study's completion. So in order to measure this or determine this, we have to look to see whether or not follow-up was complete. And complete follow-up is one of the most important parts of a well-conducted randomized controlled trial. So ideally, at the end of a trial, we want to be able to know the status of each patient with respect to whether they experience the outcome of interest or not, for all the patients who are initially enrolled in the trial. So if a patient tends to drop out of the trial and they're lost to follow-up, we might not be able to actually measure their outcome, which becomes really problematic. The greater the number of patients whose outcome isn't known or the loss to follow-up, the more likely a study is going to be potentially compromised and the results of the study are going to be biased. The reason that this results in bias in a study is because patients who are lost to follow-up also tend to have different prognoses or patient characteristics compared to those who actually stay in the study. Patients could disappear or drop out of the study because they're actually having an adverse effect related to the medication, or conversely, because they're doing really, really well. So they didn't return for an assessment. So then we're actually missing those groups of patients for the study, and this leads to substantial bias, and it's called selection bias, and it's a really big issue in randomized controlled trials. So you want to make sure that follow-up is as complete as possible. A second question we need to look at to determine whether or not prognostic balance was maintained at the end of the study is whether or not patients were analyzed to the groups in which they were randomized. So the benefits of randomization are actually undermined when patients who don't receive their assigned treatment are omitted from the analysis. Or the events or events are counted that occurred in non-adherent patients who were assigned to the treatment against the control group. So this is all typically all about adherence. So a lot of the time in a randomized controlled trial, a patient will be assigned to the treatment group or the intervention group, but they might not actually take their medication. But in the whole randomization process, patients are balanced with respect to the intervention and control group. So if you don't actually analyze, if you remove the patients who didn't adhere to or take their treatment in the intervention group, then randomization and patient balance with respect to their characteristics isn't going to be maintained. And this is especially the case if adherence is related to prognosis or whether the probability that the patient's actually going to experience the outcome in the trial. So a lot of the time, patient characteristics, or rather the medication is actually causing a side effect that might cause the patient to stop taking the medication. And if that side effect is related to the outcome of interest, then this can really produce issues in the study. So what investigators tend to do in these situations in order to prevent bias is they will actually analyze patients using the intention to treat principle, and they analyze all patients in the group to which they were actually initially randomized, irrespective of what treatment they actually received. So what this means is that even if a patient doesn't adhere or take their study medication or the intervention medication, they're still going to be analyzed as part of the intervention group, because that means that prognostic balance will be maintained between the intervention and control group when you're analyzing the results of the study. But typically, investigators also conduct a per protocol analysis where patients are analyzed according to the treatment they actually received in the study. So if a patient, didn't actually, they were assigned to the intervention group, but they didn't actually take the study medication, they would be analyzed as part of the control group. And typically what's done is that the intention to treat and per protocol analyses are compared to one another. And if there's huge differences in the results, then that can be a bit problematic. So that's how the non-adherence to study medication tends to be dealt with in this particular setting. So lastly, we want to look at whether or not the results can be applied to patient care. So obviously, we're not, most of us, I'm not going to make assumptions that no one in this group is a clinician, but a lot of the time in clinical practice, what we want to do is determine whether or not the results of a clinical trial are actually applicable to patients in the real world clinical setting. We're not going to expect you guys to know which patients would be treated with a new study medication if it came onto the market and was approved. We'll give you like a specific setting or situation or clinical practice population that we'd want to compare the study population, the RCT to, but it's just important to realize that we need to think about the differences in the study populations between patients who are enrolled in the RCT and then patients who would actually receive this medication in clinical practice, because if the two groups are very different from each other, then questions are raised with respect to how applicable the results of the RCT are to the real world clinical patient population. So you want to answer the question, were the study patients in the RCT similar to the patients you would expect in clinical practice? So again, we'd give you an example of a specific patient population to compare to when you're actually conducting critical appraisal. But if the patients you would expect to see in clinical practice that would be treated with the study medication would have qualified for enrollment in the original RCT, then you can be pretty confident in applying the results of the RCT to that patient population. And this means that the study results are generalizable. But a lot of the time, the patients who are in clinical practice who are actually going to be treated with the new study medication have very different characteristics than the patients who are actually enrolled in the trial, and they wouldn't have actually met the studies or the RCT's eligibility criteria. So patients in clinical practice could be older or younger, might be sick or less sick, or might have different comorbid diseases that would have meant that they would have been excluded from participation in the original RCT. So if the two study populations are that much different between the RCT population and the real world clinical practice population, then these results might not be as applicable in the real world, and it might not have the same generalizability. So just one last note. So of course, we've gone through this whole critical appraisal lecture, and it's important to point out that you're actually going to use all of this information in order to conduct your own critical appraisal later on in the course. So you're actually going to get a published randomized controlled trial where you're going to have to read it, and then you're going to have a set of questions that you're going to have to answer that are based on the questions that we just went over for this in this particular lecture. So yeah, you're going to actually be able to apply the theory that you've learned today in to an activity in small groups. So you might have to look at this lecture again as a refresher right before you conduct your own critical appraisal. So I hope that this has been helpful for you.